Hello, good evening. My name is Bernadette Alexander, and today I'm presenting my DNP project title, Implementation of Respectful Maternity Care, Clinical Practice Guidelines to Improve Equitable Maternal Health Outcomes, a crucial step towards reducing disparities. In this presentation, I'll briefly review the background and problem, describe the agreed to appraisal of the AWHONN Respectful Maternity Care Guideline, share the results, and discuss how this work can support more equitable maternity care in practice. The United States continues to face a maternal health crisis with clear and persistent racial disparities. Black maternal mortality remains twice to three times higher than for white women. And in some regions of the country, the disparity rises to as much as 8 to 12 times higher. These outcomes are not random. They are linked to structural racism, inequitable access to care, and disrespectful or dismissive treatment during pregnancy and during birth. Respectful maternity care, or RMC, is an evidence-based approach that emphasizes dignity, autonomy, and person-centered care, making it a critical strategy for advancing equity in maternal health. Despite growing attention to maternal health disparities, reports of mistreatment, lack of autonomy, and disrespect during childbirth remains common, particularly among women of color. Studies show that many patients feel ignored or silenced when they report serious symptoms. While guidelines exist to promote respectful, equitable care, their quality and readiness for implementation can vary. The purpose of this project was to use the Agree tool to evaluate the AWHONN Respectful Maternity Care Clinical Practice Guideline, identify its strengths and limitations, and determine how well it can support equitable care across maternity settings. This project was guided by Lenginger's culture care theory, which emphasizes cultural, congruent, person-centered care that honors patients' beliefs, their values, and practices. It also drew on the Cycle to Respectable Care framework, which explicitly addresses racism and inequity in maternity care and centers the lived experiences of Black birthing people and other marginalized groups. In addition, the Future of Nursing 2020-2030 reports highlights health equity as a core responsibility to nurses. Together, these frameworks support an evaluation of the guideline that prioritizes culture, respect, and structural determinants of maternal health. This guideline was appraised. This was a guideline appraisal project using the Agree-to instrument. The AWHONN Respectful Maternity Care Guideline was the focus of the evaluation. Agree-to is a validated tool that examines 6 domains: scope and purpose, stakeholder involvement, rigor of development, clarity of presentation, applicability, and editorial independence. Each of the 23 items was scored on a 1 to 7 scale, and scores were converted into standardized domain percentages. The evaluation focused on how clear, rigorous, and usable the guideline is, and whether it meaningfully supports equitable, respectful maternity care. In this project, the sample was not human participants, but rather a single clinical practice guideline. The AWHONN Respectful Maternity Care Guideline was selected because of its national visibility and explicit focus on respectful, trauma-informed, person-centered care. It is intended for maternity nurses, midwives, and interprofessional teams across prenatal, intrapartum, and postpartum care. The appraisal examined how well the guideline communicates its scope and purpose, who it is written for, and whether its recommendations are clearly aligned with the goal of equitable and respectful care. For data analysis, I followed the agreed-to user manual to calculate standardized domain scores. Each agreed-to item was scored between 1 and 7. The domain scores were then converted into percentages, which allowed for easier comparison across domains and with findings from other guideline evaluations. This method has been used in previous studies, including work by Hoffman, Eber, and colleague, and Penfold and colleagues, to assess overall guideline quality and readiness for implementation. The focus here was on clarity, on rigor, stakeholder involvement, and applicability to real-world maternity care. The agreed-to results showed a mixed pattern of strengths and opportunities. The highest score domain was scope and purpose and clarity of presentation, suggesting that the guideline clearly states its objectives, target population, and recommendations in an organized and easy to follow way. Stakeholder involvement and rigor of development fell into a moderate range, indicating partial but incomplete documentation of who was involved in the development and how the evidence was synthesized. The lowest scoring domain was applicability, which points to a lack of detailed implementation tools, resource discussions, or strategies to address barriers in practice. This slide summarizes the key findings of the agreed-to evaluation. The strongest domain was scope and purpose and clarity of presentation, which indicates that the guideline is clearly written, it is well structured, and identify its target audiences and goals appropriately. Stakeholder involvement and rigor of development were moderate, suggesting that while there are some evidence review and engagement, these processes could be more transparent. The lowest score was applicability, which indicates a lack of tools or resources to support implementation. Overall, the guideline presents a solid foundation for respectful maternity care, but would benefit from more explicit implementation guidance to effectively support equity efforts. The guideline has several important strengths. It provides a clear statement of scope, of its purpose, and intended users. It strongly emphasizes respectful, person-centered care, including autonomy, informed consent, emotional support, and shared decision making. The recommendations are evidence informed and aligns with broader efforts to improve maternal health equity and experience of care. These strengths suggest that the guideline is conceptually sound and relevant, and that it can serve as a strong foundation for integrating respectful maternity care into midwifery practice. At the same time, the appraisal identified several gaps. The lower applicability scores reflect limited guidance on how to implement the recommendations in real-world settings. There is little detail on workflow tools, resource needed, or metrics to track progress. The guideline could also benefit from more explicit language on structural racism, implicit bias, and the unique vulnerabilities of Black birthing people and other marginalized groups. In addition, there are few concrete strategies for audit, for feedback, or measurement, which are critical for holding systems accountable and demonstrating improvement in equity and respectful care. This project has a few key limitations. First, it focuses on a single guideline, so the findings cannot be generalized to all maternity care guidelines. Second, although agreed to instrument is a validated instrument, the scoring process involves some subjectivity and reflects perspective of one primary reviewer. Third, this project did not include implementation of the guideline or measurement of patient outcomes, so its real-world impact on maternal health equity remains to be tested. These limitations highlight areas for future research and quality improvement work. Overall, the evaluation suggests that respectful maternity care guideline is a strong foundation for promoting respectful, person-centered care, which aligns with national calls to address maternal health inequities. However, gaps in applicability and explicit equity content limits its ability to drive change on its own. To truly impact outcomes, health quality guidelines must be paired with implementation tools, staff training, and structural interventions. This project underscores the importance of not only asking whether a guideline is evidence-based, but also whether it is practical, equity-focused, and ready for use in a busy clinical environment. The implications for practice are significant. First, respectful maternity care principles should be integrated into staff orientation, annual competencies, and ongoing professional development for nurses and midwives. Second, organizations can embed cultural humility and anti-racist practices and shared decision-making into communication standards, care pathways, and debriefing practices. Third, the Respectful Maternity Care Guideline can serve as a framework for chat audits, simulations, and interprofessional case reviews. Finally, partnering with community members and Black birthing people to adopt and implement respectful maternity care recommendations can ensure that changes are grounded in lived experience and truly responsive to patient needs. A key implication of this project is the need for nurse leaders to advocate for the integration of respectful maternity care principles into formal policy. Respectful maternity care concepts should not exist only in guidelines. They should be embedded into unit protocols, staff competencies, and performance evaluations. The agreed to findings also highlight opportunities for leadership to improve how future guidelines are developed by ensuring stronger stakeholder involvement, better documentation of evidence review, and clear implementation tools. On a broader level, nurse leaders can advocate for respectful maternity care principles to be incorporated into state regulations, accreditation standards, and organizational equity initiatives. By approaching RMC, respectful maternity care, as both a clinical and policy priority, we can drive sustainable change that supports respectful, equitable care for all birthing individuals. In conclusion, the AWHONN Respectful Maternity Care Guideline demonstrates strong quality in several domains and is an important tool for improving the experience of care in maternity settings. However, enhancing its applicability and making it equitable, focused, more explicit could increase its impact on maternal health disparities. Next steps might include developing implementation toolkits, piloting the guideline into clinical settings, and evaluating patient-reported experiences and outcomes. On a personal level, this DNP project has deepened my skills in evidence appraisal, equity-focused practice, and leadership, and it has reinforced my commitment to evidence, to advancing respectful, just maternity care. Thank you very much for listening to my project, and please note my slides, my references. These slides list the full set of scholarly sources that informed the project, including guideline development, literature, agreed-to studies, maternal health equity research, and frameworks related to respectful maternity care and nursing leadership.